Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Ms. Christine Quinn, Senior Improvement Lead at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Quinn.
Thanks very much, Val. Hello and welcome to our new on-call series, Data Bootcamp, How to Get Your Data into Shape. I'm Christine, Senior Improvement Lead here at CFHI, and I am pleased to be your host today as we present the first session in this series, which will focus on introducing healthcare data for improvement. I am super excited because today we are joined for actually over 100 organizations from across Canada, and in fact we did have several international registrants. And as I introduce our guest speakers, please do take a moment to introduce yourselves into the chat box. Let us know who you are, where you're from, and that's also the place where you can ask your questions. So today joining us is Melanie Rathgaber, she is a CFHI measurement coach and president of Merge Consulting, specializing in using data for quality improvement. Melanie's improvement experience spans a variety of healthcare settings, including primary care, mental health, and acute care. Melanie led improvement and measurement initiatives at 2 provincial quality councils in Saskatchewan and in British Columbia, and more recently switched her focus to mental health, where she worked firsthand with staff and patients to measure and improve the quality of care. We're also joined today by Trevor Strom, who has nearly 2 decades of healthcare informatics and analytics development experience. In his current role at the Winnipeg Regional Health Authority Emergency Program, Trevor leads the development and implementation of informatics and analytics tools for use in healthcare quality and performance improvement initiatives. He's also the assistant professor with the Department of Emergency Medicine at the University of Manitoba, where he participates on clinical and operations research projects and lectures on topics related to data science, informatics, and quality improvement. And of course, none of this would be possible without our producer, Sheena Powell, who is here with me behind the scenes in Ottawa. So this on-call series is designed for healthcare stakeholders who are responsible for ensuring that high-quality data are available for quality and performance improvement initiatives and those who use the data. And over the course of the 3 sessions, participants will gain a better understanding of how to assess data quality from various sources, including electronic data and manually collected data, which approaches, tools, and techniques to apply to improve the data quality for improvement, and how to establish appropriate data management policies to ensure that you have useful data available to those who need it when they need it for improving healthcare. Today's session, specifically, what we're going to be talking about is we're going to be introducing you to what healthcare data quality is and how it impacts performance measurement. We'll drill down a little bit into how to use data effectively to accelerate quality improvement initiatives and look at the various dimensions of quality, data quality, and data-driven performance. And we'll introduce you to measuring, evaluating, and sustaining improvement using data. I'll just take a couple of minutes to give you just a brief backgrounder about CFHI. So the Canadian Foundation for Healthcare Improvement is an independent organization, and we're funded by the Government of Canada. We're dedicated to accelerating healthcare improvement and transformation for Canadians. Our mission is to accelerate healthcare improvement and transformation for Canadians, and to do this we collaborate with governments, policymakers, health system leaders to convert evidence and innovative practices into programs, tools, and leadership development. Our goal is to spread successful improvement across Canada. So now I will turn it over to Trevor Strom to kick off our very exciting series.
All right, well, thank you very much. Good morning or good afternoon to everyone, depending which time zone you may be situated in today. Thank you very much for joining us on this call regarding healthcare data quality. I think I would like to start off the session just by asking everyone to think for a minute about where do most of your healthcare data come from? What kind of source systems do you have? Where is the information originating from? Basically, what kind of data do you use in your day-to-day healthcare improvement activities? So if we can just take a few seconds, you can use the chat option on the Adobe Connect to enter in one or two things in terms of where your current health data comes from. And then what we're going to do is, as you're doing that, we can start thinking about what healthcare data is. So the first session, or the first section of the talk today, is going to be about, where does healthcare data come from? What is healthcare data? And then we're going to talk a little bit about healthcare data quality and the various dimensions of data quality. And then the third section is going to be, how data quality can impact how we measure, evaluate, and sustain improvement. So those are going to be the three main sections that we're going to be focusing on today. So as you're thinking a little bit about where the data that you use for healthcare improvement comes from, I'm going to talk a little bit about some of the common sources of healthcare data. We can have human-generated data, and the human-generated data typically is that unstructured and semi-structured data that gets entered into things like electronic medical records, and this would include things like physician's notes, email, paper documents, sort of anything that humans would enter into an electronic medical record, electronic health record. Another emerging, and the human-generated data is data generally that we know how to use fairly well. We're fairly comfortable using human-generated data for a lot of our quality improvement efforts. Another emerging source of data for healthcare comes from web and social media data. So this is clickstream data and other interaction data from social media such as Facebook, Twitter, LinkedIn, and various blogs. And this is an emerging source of data that healthcare organizations are using to do things like sentiment analysis or better understanding what patients are feeling or thinking. Another source of data that we use that is becoming more accessible is machine-to-machine data. And machine-to-machine data is part of this so-called Internet of Things, and this would include data that comes from readings from the various sensors, meters, and other devices that we have in our healthcare organizations. We have transaction data, which is commonly used, such as healthcare claims data and other billing records. And also emerging is more biometric data. This can include everything from fingerprints, genetics, handwriting, blood pressure readings, medical images, retinal scans, and similar types of data. So each one of these types of data represent a potential source of information while we undertake our healthcare improvement activities. However, each one of them also presents various challenges in terms of managing the data, using it, making sure that it's suitable for what we need to do for our healthcare improvement efforts. So if we go back then for a second and consider what data is, there are various definitions of data, but I like to go with sort of a basic one, which is that data is the raw material of information. So the data sources that we have on the previous page certainly provide a list of various types of raw material, of the various raw material that we can have in the form of data. But just like any raw material, we must be able to process that data in order for it to become useful. And as an analyst who works on data quite frequently, just looking at raw data that's exported from electronic medical record or other data source isn't really particularly helpful, doesn't give us that much insight. So the processing then is how data starts to become information that is ultimately useful for healthcare organizations to better understand their operations and their overall performance. Now, one of the primary reasons for undertaking data or using data analytics and data informatics is to base actions on data, or evidence-based decision-making. And so we know that the data that is stored in source systems is not easily accessible or easily used for quality improvement. Usually the data that we get out of our various source systems need to be massaged or cleaned in various ways. So if you imagine giving a quality improvement team just a data dump of a whole line list of data, it's not going to be that useful for them. So when we get a request of data from a quality improvement team or from an executive or something, the request for data usually stems from the need for information to help understand a problem, identify issues, or evaluate various outcomes. So it's not just a request for raw data. They're looking for an answer. So then analytics can assist us in turning this raw data into information by using this flow that you see at the bottom of the slide. And this basically shows that we can take our data, go through some analysis, including data cleaning, etc., which then provides information to the decision makers or people who are undertaking improvement activities. And then the goal for that would be for them to take some sort of action and ultimately achieve the outcomes that they're looking for. This is a bit of a value chain then, in terms of starting off with our raw data and turning into action, which ultimately gives us the outcomes that we're looking for. But none of the decisions that we made, none of the actions that we take, or anything that we do with healthcare data can actually be very helpful unless we know that we've got high quality data that we can use, that we don't have, any questions about, the quality of our data. So I've sort of drafted, there's a lot of literature on data quality and a lot of thinking about this. I've tried to distill the data quality into these 5 tenets, right? And so if we look at, the 5 tenets of healthcare data usability and quality, I always say that the first place that you need to start is actually defining the problem or the question being asked. And so we're going to find out a little bit later that quality is defined by the fit for use of a particular data set. But if you don't know what you're trying to use the data for, it's very hard to define, whether or not a data set is high quality or not. Next, you need to know what data is available and what it represents, or this is the context. So what are you working with? Do you have clinical data? Do you have process-related data, administration data? So what is the data that you've got, and what is that data telling you about what's happening either on the front lines or in your business processes? Next, you need to know where and how the data is stored. So this is a bit more of a physical manifestation of data, whether you've got the data stored in SQL Server databases, Access databases, spreadsheets, etc. You need to know where that data is, and how it is stored is actually important too, because you may have numerical data which is stored physically on a database in a text format, etc., which can actually complicate the analysis that you want to do. And then you need to understand the business and operational clinical value of the data. So ultimately, is the data and the information that you have relevant to the question being asked? And finally, you need to analyze and apply that data appropriately. So if you have a good data set, but you're not applying the appropriate analysis, if we're not using that data properly, then any results that you have may come into question as well. So next we're going to talk a bit about the different types of data that you may encounter in your healthcare improvement efforts. And one of the first common types of data that we would see is categorical or nominal data. And categorical or nominal data typically is data that is mutually exclusive but non-ordered categories. So you can see here we have a graph which would be counts of various emergency departments. We would have counts of various EDs. We can put them into bins, but the order of the bins that we put them on the graph doesn't really make much difference. We can sort these any way we want, and the data will be just as meaningful. The next type of data that we commonly deal with is ordinal data. And ordinal data is variables where the order matters, but not the difference between the values. And so one of the common uses for this is, or examples of this would be our CTAS, or the Canadian Triage Acuity Scale, where we have values ranging from 1 through 5, 1 being the most acute, 5 being the least acute or the least sick. But we know that 1 are more sick than 5, but the difference between a 1 and a 2 or a 2 and a 3 is impossible to quantify. Then if we look at the two next types of data, we've got interval data, and interval data is where measurements where the difference between the two values or between two values is meaningful and consistent. So these would be things like temperature, degrees Celsius, degrees Fahrenheit, etc. And you can see an example of a graph there that we're just plotting values along a graph for patient temperature. You'll also notice that I subliminally implanted the notion of data quality, because you're going to be wondering whether or not that 30 degrees on October 6th is actually a real temperature value, or whether or not it's some sort of data quality issue. And then the last type of data that we encounter is ratio data. And ratio data is a measurement where the difference between two values is meaningful and consistent, much like interval data. But there's also a clear definition of zero. That means that when we have zero weight, for example, or when there's zero something, there is nothing. And examples of that would be degrees Kelvin, height, and weight. Whereas if we look at the previous example with temperature in degrees Celsius, 0 degrees Celsius doesn't necessarily mean that there is an absence of temperature, although it can certainly feel like that on some days. So if we talk about using data responsibly, then there are certain things that we can do with the data based on various operations. So we can do things like, frequency distributions and counts with almost every type of data set that we've got. But when it comes to calculating medians and percentiles or maximums and minimums, it doesn't really make sense to do those with nominal data. But ordinal data, interval, and ratio, you can perform that type of analysis on it. You can add and subtract interval and ratio data, as well as do basic stats on it as well, such as the mean, standard deviation, or calculate standard errors. So when you're working with your data set, it's very important to be able to understand what the data you've got, what you can reasonably do with it, so that we don't run into analysis errors performing, say for example, doing an average on an ordinal data, for example. So that is our introduction to sort of what data is. It's a very high-level introduction, but hopefully it gave you a sense of what the variety of types of data that we can see, and the various things we can do with data, or things that we can't necessarily do with data. So we're going to move on into the next section now then, which is Introduction to Data Quality. And just sort of like the beginning of the first section, I would just ask everybody to enter in one or two of your biggest data quality problems. So in your day-to-day operations within your healthcare organization, what are some of the data quality problems that you encounter on a day-to-day basis? So since we're talking about data quality, we might as well start to define it. And if we ask ourselves, what is high-quality data? Quality expert Joseph Duran stated that data are of high quality if they are fit for use in their intended operational decision-making and other roles. And so this is where I mentioned in one of the earlier slides about you need to know what your problem is or what your question is as you start off using your data, because really only by understanding how you want to use the data and what questions you want to answer are you really in a position to be able to start to assess whether the data that you have is high quality or high enough quality. One thing I want to caution against is aiming for perfect data quality because it's impossible, and it's not actually necessary. So if you can aim, in our next presentation, we're going to talk a little bit about some strategies that we can use to improve data quality, but just keep in mind that it's not possible to get perfect data quality, and it's not necessary. Seeking perfect data will actually stall important analyses and improvement activities. So if you're worried about getting that perfect data set, you might as well just work with what you have, understand the data that you have, understand where it's good, where it may not be so good, and work with it. So what are some of the impacts then of data quality on the data use? Well, if we have data that we would consider poor quality, there's a few things that it can do for us. It can decrease our ability to detect signal versus the noise. And I know that a lot of work that we do from a quality improvement perspective surrounds being able to detect the impact of a new type of staff member or a new type of process or some new technology intervention. And so if we're trying to detect the change that something has made in, say, a length of stay or some other process definition interval, we need to be able to know for sure that, or we need to minimize the data noise so we can actually have a chance of seeing the impact that this innovation or this change actually had. So what does this noise represent then, or what causes this noise? The noise really would be increased variation in data is one potential manifestation of noise. And the variation, if we start to see increased variation in data, for example, if we start to see fluctuations in length of stay, or if we start to see fluctuations in cases of sepsis or increased falls in the emergency department or variations in that metric, if we don't actually have high confidence in our data, we may be asking ourselves whether or not the fluctuations that we're seeing are a result of actual performance, or are we just seeing a manifestation of poor data quality? So is what we're seeing real or just an issue with our data? So we know then that decreased certainty in the results of our analysis will impact our efforts at improvement. So either we may not be able to identify truly where our issues are in our overall performance, or when we implement a performance improvement, we may not be able to see the true impact if the data that we have around that process or that technology implementation is not accurate. So if we look then at the various data quality dimensions, I think when we talk about data quality, one of the first things that first things that we would see in terms of data quality dimensions would be accuracy. And accuracy is a reflection of how well the information within the data or otherwise derived from the data reflects the actual reality it's intended to measure. And so some of the mitigation strategies for improving accuracy would involve having end-user training so that they can use the source systems more suitably, that the data going into the system is accurate. Engage in some source system validation so that for example, dates cannot be entered incorrectly with month, date, year, or day, month, year, or other things, or that temperatures can't be entered that would be out of a regularly expected range. And then workflow and data alignment. So we need to make sure that what we think we're measuring actually is measuring a various process. So if we have interval times that would be from, say, registration in the emergency department, or sorry, from the time that a patient is triaged to the registration interval, then we want to make sure then that we're measuring from the beginning of triage to when registration occurs, and not maybe the end of triage from to the time registration occurs. Another issue with data then is timeliness, and timeliness is a reflection of how recent and up-to-date the data is at the time it's available for use by decision makers. So if we need to make decisions based on information that we had yesterday and the data that we have is only 3 months old or 6 months old, it's not really that helpful for us. And so some mitigation strategies for timeliness would be to ensure that we have more frequent data, more manual data collection, increased frequency of source system data transfers, or any other way that we can get data into the hands of decision makers more quickly. And this may involve work with your information technology groups or other groups to ensure that we can get data into the systems more quickly. Another issue or data quality dimension then is comparability, and this would be the extent to which data is consistent over time. And to ensure that we have comparability, we can conduct data definition reviews, we can do periodic audits on the data we have, as well as end-user refresher training, so that when we look at data a year ago compared to the same data that we're looking that happened yesterday, that the data is comparable, that we're still measuring the same things and we're using the same processes and procedures. Another data quality dimension that we can discuss is usability, and this is how easy it is to access, use, and understand the data. So to ensure usability, we can ensure that the data that we have is thoroughly documented, that we can design user-friendly data access portals, and create clear data visualizations or other analyses so that the people who are using the data can actually understand it and remove the risk of error or misinterpretation. Another key data quality dimension is relevance, and relevance is a reflection of how well the data meets the current and potential future quality improvement and decision-making needs of the healthcare organizations. So we actually have lots of data within our healthcare organizations, but is all of it necessarily relevant to the pressing business and clinical issues that the organization is tackling at this point? And so to ensure that we have relevant data, we can work with our stakeholders to identify high priority information requirements, and we can just focus on ensuring that we have alignment between organizational goals and the analyses that we're performing. And then completeness is fairly self-explanatory in terms of how much of all the necessary data is available to decision makers. And so once again, to ensure that we have a complete data set, we would identify high priority information requirements with our key stakeholders, and as well as automate data collection where possible, because we can have gaps in in data collection which can impact our completeness of the data. Finally, we have conformity and consistency. Conformity is how well the data available conforms to the expected formats, such as standardized nomenclature and coding schemes. And with this, we can identify data standards, recommend and monitor their use. We can conduct data definition reviews and audits just to ensure that the data that we have actually is conforming to the expected formats. And then consistency is how well values agree across data sets and the extent of agreement exhibited by different data sets that are describing the same thing. Basically, for example, in our world here, in the world that I work with, we would want to make sure that we have consistency between our admission, discharge, transfer data, for example, and our emergency department information system data. So are we coding things like patient admissions the same way, or do we have consistency between those two data sets, or other data that we want to bring on into the work that we're doing? So just a few examples here in terms of data quality manifestations. These are real-world examples that I pulled from my everyday work. When we look at this example here of emergency department length of stay, we see that spike in the data, and that is fairly obviously a data quality error where we have one or a few values that are far outside the expected range, and it shows up as a spike on the chart. And interestingly enough, when our end users see this information, their first comment is, "Wow, what happened then to cause such a long length of stay?" Their first thought isn't data quality. And so as, informatics and analytics and quality improvement folks, we need to make sure that we can clean our data set and either remove data quality errors like this, or at least have some sort of flag to identify that there is an issue with the data. And this is an example of completeness, for example, where we're tracking consult times, and then suddenly we have a gap in the data, and this is because the person who was at the time taking the data from the charts and coding it into our database for this particular type of analysis decided that they were going to take a month off, and we have this gap in data, and no one had gone back to fill that information. So we have a gap in the completeness of the data set. So these are just some examples of how data can manifest, or sorry, data quality can manifest quite visibly in some of the analyses that we do. I think what we need to be very wary of, though, is those data quality issues that don't become quite as visible when we do visualizations like this. So I'd like to turn over now to Melanie to offer some reflections on what we've just been talking about.
Thanks, Trevor. My name is Melanie Rathgaber, and I've been working with Trevor on some of this material, and a bit of a counterpart, as if you will, because I self-describe myself as a quality improvement professional who uses data really, really regularly in my work and in my projects, and but I don't consider myself to necessarily have a great data background, or not a statistical background really at all. So it's always important to me to be able to rely on people that have a bit more understanding of these issues to work with them, so I can think about how useful the data is for purposes on the quality improvement end. So just a few things I was thinking about and that I noticed coming into the chat line. Trevor, I thought it was really interesting actually when you first asked about where data quality or data comes from, and there was a few different answers. Some was from the EMR, some was from things like lab data, things not even for patient care. I saw a couple of things from billing data. But no one says that our data comes from a data source that's specifically meant for performance measurement or quality improvement. So it's a good reminder that we're using data that was collected for a different purpose, and we're using it to try to measure quality of care. And I think that's where a lot of the some of the potential errors and the problems with accuracy and consistency can come in. What I was really heartened to hear Trevor be able to talk about, and I think that probably in our second series we're going to go more into some of the nuts and bolts of this, is those mitigation strategies. Because as a user of data for quality, what I do know is, just echoing what Trevor said, you can't wait for the perfect data. And if you do, and if you think you can wait for perfect data, if that's what you're searching for, it's just not going to be useful for you anymore, because at that point there's going to be too much of a time lag, and it may be important to try to get that data as clean as possible before it goes to external organizations or to different reporting bodies. But to use it for quality in your own organization, it's probably more important to make sure that it's timely and that you're aware of some of the other issues around the accuracy and completeness. But you need to be able to find some mitigation strategies for those things pretty quickly. The other thing that I just wanted to point out, and I saw a couple people talk about problems or communication problems between those who are inputting the data and those who are extracting the data, and then maybe again between the end users of the data. And I think that's an interesting sort of communication loop to look at. And I wonder if part of the problems that we have is that we're not really great at communicating about that stuff yet, and that we need sort of better ways to communicate. From a QI perspective, if I can be really clear to a data analyst, let's say, about what I'm looking for and what I'm willing to live with or accept, they may be able to help me more quickly get me some data that at least is usable at my level. But the other thing I think about is because all that data is being input for other reasons, because it's being input for patient care or for administrative reasons, I think a lot of the times our people that are inputting it don't sort of understand what all we're using it for. And if they maybe had a better sense of, we're actually also using this data to track our patient outcomes over time, and this is why it's important for you to do that. I wonder if that would help. And I don't think we can do it sort of across the board, but as Trevor said in one of his last slides, if something is a real priority for the organization and we're pulling off that data, maybe there's ways to start some improvement strategies around improving the data input and letting the people know and giving them education about this is why this is important, this is what we need the high-quality data for, this is how it's being used, this is a priority area for the next 2 years, so we're really going to be focusing on high-quality input there. So that's my reflections on this piece. I'll turn it back to Trevor. I just wanted to let you know that I am monitoring the chat, as Trevor is also. So if you had any reflections or questions throughout the next little while, feel free to type them in chat, and we'll try to address them for sure. So back to you, Trevor.
Oh, thanks. Can you hear me? I think that,
Yes, we can.
Okay, thank you. You raised an interesting point that nobody or very few people mention that they're using a data set or a database that is specifically geared towards performance improvement. And I think that's a really good point. As you mentioned, that most of the data that we're using is really the data that we have for quality improvement and performance improvement is really secondary use. So it's used in some other format. And so I think that's a really good segue into what our next section is going to be in terms of what is quality and how do we measure quality, because ultimately we need to take our data, which is some sort of, some raw material, apply some analysis to that, which then turns it into information that we can use. And so we need to know then how data quality fits into this, so that is the data timely enough to be able to develop indicators for, or is it accurate enough to understand where we have performance improvement issues. So if we look then at the next section, which is measuring, evaluating, and sustaining improvement, if we start off with the question about what quality is, there's a few common definitions, but quality is frequently discussed and highly sought after in healthcare, but it really does mean different things to different people. And so two common definitions of healthcare quality are doing the right thing at the right time for the right person and having the best possible results. And this is coming from the Agency for Healthcare Research and Quality. And then the Institute of Medicine defines quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So our data that we have that needs to be of high enough quality that we can actually see whether or not we're achieving these quality goals. So some of the common ways that we use data for healthcare improvement then are identifying improvement opportunities. So if we look at our performance, are there any areas in our performance that are not meeting our expectations or our target performance? And what are our expectations in our target performance? We can use data in healthcare improvement for assisting evidence-based decision-making. So are the decisions that we're making and the actions that we're taking based on our best available evidence? We can use our data to evaluate the process changes, and as well as something that often gets left behind, which is long-term sustainment. So we can evaluate, or very often we'll evaluate something in the short term, but in order to really sustain improvement, we need to evaluate in the long term. And the long-term evaluation of our improvements, staying on top of process changes or workflow improvements or new technology adoptions, require that the data that we have is absolutely consistent along that time period, so that we're not introducing doubt or we're not seeing a change in performance merely as a result of bad data as opposed to a change in performance. So these are some things how even data quality can impact our ability to evaluate and sustain changes over the long term. At the end of the day, though, quality must be defined in terms that are quantifiable, meaning that they can be measured, monitored, analyzed, and ultimately acted upon. So one thing that I do want to talk about is variation in performance, and data quality issues, as I mentioned before, may increase the variability and uncertainty in the analysis that we do, but there's also other potential sources of variation, and the variation that we see is what we would typically plot on statistical process control charts. And there's actually been some previous CFHI webinars where Melanie has done some outstanding work discussing run charts and SVC charts in terms of how we can use these types of charts to detect actual performance variations. But at the end of the day, if we have poor data quality, any variation that we see in performance, we may have some uncertainty around that, and as a result, this uncertainty may impact some of the decisions that we would make. But two of the common sources of variation that we would be looking at in performance data would be common or random variation, and these are causes of variation that are inherent that's in the work that's being performed, and they affect everyone who performs this work and really affects all outcomes. So common cause variation is predictable and expected and can be caused by many reasons, ranging from complexity of the patient needs to materials available. So this might be the case, for example, where if we use triage times in the emergency department, we know that, every patient on average takes about 6 minutes to triage. Some patients may take a little bit longer. Some patients may take a little less. But, we see this common or random variation in our triage times all the time, but they all sort of hover around the 6-minute mark. What we do see, though, sometimes is special or assignable causes of variation. These are causes of variation that are external to the system or the work being performed, and they do not occur all the time, and they arise due to special circumstances. So this may be an instance where, if a patient came in and they had a very long triage time, for example, it may be that they had a communication issue. They didn't speak English, or they weren't able to communicate very well with the triage nurse, and we may see some time that it takes for the triage nurse to track down an interpreter and be able to go through the whole triage process. So rather than seeing a triage time of around 6 minutes, it may be maybe 20 minutes, 30 minutes. So this would be a special cause and variation, but not necessarily a data quality error. It wouldn't be, we would sometimes see 30 minutes, but that would be as a result of these special or assignable causes, as opposed to where we had a system glitch or somebody entered in a wrong date or time and we got a 30-minute triage period. But if we have a lot of variation in our data as a result of data quality issues, these types of causes of variation may be more difficult to discern. Generally, when we're looking at healthcare quality improvement, then healthcare quality and performance must be looked at from multiple perspectives. And so these are generally the three elements of healthcare quality measurement as defined by Donna Median are structured, process, and outcomes, and these form a continuum of quality measurement. So ultimately, we also know then that the process measures must be linked to outcomes if they are to be effective measures of quality. On a very high level, structured basically represents things like number of nurses, number of doctors, number of resus rooms, sort of basic infrastructure, physical components of the organization which may impact on the overall the process or performance of an organization. Then we have the process, and the process, of course, is the way work is done, how patients are processed, how can we expedite patient flow, how are we ensuring that stroke patients get to CT scans in a timely manner, etc. And then, of course, the outcomes are ultimately, did they survive the ED encounter or not, or did they have a readmission at some point? What is their long-term outcome? So these are the types of things that we look at when we want to measure healthcare quality, and these are the things that we need to be able to quantify. And the way that we typically quantify our healthcare information is by measures, for example. A measure is a quantitative value that represents some aspect of patient care and may be linked to a specific quality improvements initiative. Measures, I don't know, I sort of view these as that they have not necessarily been processed, but we may group things into some sort of logical manner. So we may be looking at, in the graph here as an example, maybe just number of patients triage. It doesn't necessarily tell us much more than that, just that we've had around 140 patients triage per day in the time period there. But if we want to get a bit more sophisticated, then we start talking about metrics. And metrics then are some aspect of healthcare quality or performance to which a quantitative value is attributed for purposes of monitoring and evaluation. So this may be over a given time period or at a point in time. And some of these examples of metrics then would be over some time period, so such as a length of stay, number of patients seen by a physician per shift, and a number of medication errors. So these are things that are an attempt to quantify some element of healthcare quality or performance, as opposed to just binning of data, for example. And then sort of where the bar is set the highest would be for indicators. And indicators are metrics that are more useful for driving business decisions, because what makes an indicator different, say, from a measure or a metric then, is there's an actual specific context assigned to them. And this context or contextual information is really what separates an indicator from a metric by assigning what say, for example, what an acceptable range is and what a target assigned to the indicator might be. So rather than just looking at counts of data, or rather than just trying to communicate some information, the indicators are helpful because they tell us a bit more information in terms of whether current performance is good or bad, for example. It can help us determine how far away our performance is from reaching its performance target. So how far do we have to go before we actually do meet our overall performance target? And then indicators help us tell whether or not tell whether performance is trending either toward meeting the target or staying away or staying within the target range, or if it's trending away from the target, heading in the wrong direction, and heading outside of the range. But once again, we can see now that data quality plays a role in here, because if we're looking for these types of trends, we need to have confidence that the data that we have is accurate enough, that it's timely enough to make the decisions based on these indicators, and that the indicators that we're developing ultimately are relevant to the overall performance goals of the healthcare organization. So this is how we would visualize an indicator. One potential way we can see here that we have the triage override rate per month, for example, and this would show us what our baseline is over the last 30 days, which would be the orange dashed line, or what our current target is for triage overrides. And we can see then that data quality could impact something like this if for example, whether triage nurses weren't documenting whether or not a triage was actually overridden, and what we mean by override is whether the triage nurse selects a value for the CTAS score or the triage acuity score, whether or not the triage nurse chose something differently than what the computer algorithm had recommended. So, if we don't have high quality data around that, and that the information at the source is not being accurately recorded, then we can see where our indicators that we could use to track our trending of triage override rates, or whether or not we're within the the range we would like to be or not is having poor data quality would definitely impact our ability to discern that. And I would just like to hand it over to Melanie again for some more reflections.
Great, and thanks for the good discussion and questions on chat. And I know Trevor has some time, where we have some time for Trevor to provide his comments as well. I keep thinking about, as Trevor's talking and as I'm seeing the chat come in, I keep thinking about the value of communication between these different parties. And just thinking about on the top of my head that I think that the sort of three real parties kind of involved in some of this translation about the data quality and the usefulness are the people that are inputting the data, and then the data analysis or decision support folks, and then also the people that are at the end asking for the data, so people like operations managers or people like me, quality improvement professionals. And it's just sort of occurring to me that I think what we don't do as good of a job on is the translation to the people who are inputting the data to begin with, and asking or having them understand what that data is being used from. I'm actually just thinking of an example of a project I was involved a little while ago now, where we asked some staff to collect information on patient care processes that they didn't normally collect. And I worked with the managers of the organization on a process to do that, and the managers were sort of in charge of getting the on-the-ground staff to do it. And when I went to collect it was supposed to be just a paper and pencil thing, and when I went to collect it about a month later, everything was blank. And as a quality improvement professional, I should have known better, right? I should have known that we should have really involved them right from the beginning in how to collect that data. But more importantly, when I asked what some of the barriers were, people just said, we don't even know why. Like, we don't know why we're doing that. And that was really, that was really telling. And again, I should have known better. But when I could explain to them what we were going to be using it for, and then even better when I could show them how the results would be used or how they were used in one of their neighboring facilities, it made sense to them then. So I think that that's a real loop that we need to keep paying attention to. So people that are inputting data, when we're using it for performance or operations or quality, we should be showing it back to them, saying, and really making the link to them, saying this is from the data that you input on this, on this system or this screen or whatever it is, and this is how we pull it out, and this is what we use it for, and this is what it's telling us. And I think that that's probably something that we can all maybe do a better job of. I also just commented on or noted Trevor's point about long-term sustainability of practice changes and how we need to keep measuring things even after we've reached a target, or even when it's not named as a priority for on the dashboard anymore. But we do need to think about how long we're going to measure that to make sure it's sustainable. And I think that's something that quality people don't necessarily have at the forefront, because they're more thinking about how to make some of the changes. I think the operational people that doesn't come to mind as readily. So that's a good thing for decision support people and data analysts to remind us of, to say, we can get you this data. I know you're working on a project, but think about how are you going to be, continually measuring this over time and for how long, and just to remind us that needs to be built in. I think that's a really good message. And the other one that I think is something that needs to be said more is this idea that indicators are actually the ones that are useful for driving decisions, and a lot of that is based on because we set targets around them, or we think about what is an acceptable range of variation that we're willing to accept. And again, I think as quality and operations people, we don't naturally think that way. We want to make things better. We know that's our target. So it's a really good question, I think, for decision support and analysts to be asking back to us, to say, this is the data we can provide, this is what it's going to tell us, but think about what's your target and what are you looking for, and how are you going to know you're on target, and what are the action plans if you're not getting there? So some just ideas and fodder for discussion between all those parties, I think, can go a long way in helping build up some of those mitigation strategies that Kevin was talking about. That's it for me. Thanks very much, and back to you, Trevor.
All right. I think that, Melanie, if you wouldn't mind, one of the questions that came in was how do we go about setting targets and identifying baseline data? So I think you were talking about the indicator slide. Do you want to maybe just talk a little bit about some of your experience a bit more in terms of how you go about setting those targets and identifying what appropriate baseline data is?
Sure. I think the targets should be based on a couple factors, probably most importantly where you're currently sitting at. So we often talk in improvement that we want an aim statement that says, I want a specific target reached by a certain time, and I think that's where you can reach to. So let me just give you an example. If we say we want to have all patients on a diabetes pathway or diabetes self-management protocol, and we set a target saying, I want that to be at 70% by the end of this calendar year. I would base that target on where we're currently at. If we're currently sitting at 10%, getting to 70% might be challenging, but if we're currently sitting at about 40 or 50, I think that might be doable. And then thinking about what have other similar organizations been able to achieve. So that's when we look for benchmarks, but being careful about understanding how similar they are to us and what they did to get that result. Oftentimes we think, well, this hospital was able to achieve, this 0.05 surgical site infection rate. But if we want to set that as a target, then we need to understand what all did they do to get that. So I think it's about measuring some baseline of your own organization's performance over the past, whatever you can get. If you can get 6 or 12 months of data, and understanding where you're at, and if there's any benchmarks you want to follow, but also what they did to get there.
All right. Thank you very much. I think we've got some good questions in here, and I think that it would be, quite a bit of, I'm not sure we have enough time to address some of these questions in much detail. So what I'm going to try and do is I'm going to take some of the questions that were shared to us via the chat feature here, make some notes around them, and for our next presentation next month, I'll introduce some of those, or I'll bring up some of the questions with some answers. Also, we'll try and add a bit of a frequently asked questions section where we can address some of the questions that have come up, and hopefully we can continue to engage on this discussion of healthcare data quality. But I think in terms of the formal presentation, that is the conclusion of part one. I think we have some information on upcoming webinars as well.
Yes, thanks very much, Trevor, and that's exactly it. We will continue to grab the questions as they're coming in the chat and start to develop that FAQ document and start our next presentation in making sure that we have answered those questions. So I will just remind everybody about our second presentation in this series, Enhancing Data Quality for Improvement, that will take place on November 18th at the same time. And both Melanie and Trevor will be back again, and they'll be building on today's discussion. The third in our series of Data Bootcamp will take place in the new year on January 14th, and that will focus on effective data quality. And you can also see on the screen some of the other free on-call sessions that you can participate in. And I do want to remind everybody to visit our website to access any of our past on-demand webinars. They're now available at no cost by sending an email to the producer. I'm going to take a few moments here and ask you to complete the questions that you'll see on the screen, the poll. First question, this webinar increased my knowledge of data for quality improvement. This webinar provided me with new information about data for quality improvement. And lastly, whether or not you have any other comments, questions, or suggestions about today's webinar. So please take a couple of moments to complete the poll for us. It does help us to improve our future webinars and the remaining presentations in this series. I would also now, I guess we are getting close to running out of time, so I would like to take a moment to thank both Trevor and Melanie for your excellent presentations and for the comments and responding to the questions that were coming in, and a really nice way to connect the dots about the importance of communication when it comes to data. I'd also like to say thank you to Sheena, our producer, for working behind the scenes to make this webinar happen. And at this time then, I'd like to thank everybody for joining us and to remind you that Sheena will be sending out a link with the recording to the webinar as well as the presentation slides in both English and French by the end of this week. Thank you and have a great day.